On-the-scene video coverage of ESC 2012 is supported by PRAGUE-12.
Welcome back to our late-breaking clinical trial coverage at Day 3 at the ESC. We had a terrific presentation of an investigator-initiated study that looked at the most vexing group of patients we deal with, patients who require anticoagulation for either AFib or a mechanical valve who then need a stent. This is a problem that the investigators looked at dropping aspirin as a strategy. So they compared the triple antithrombotic therapy with warfarin, aspirin, and clopidogrel to a strategy of warfarin and clopidogrel alone. And they found very interesting results. Not surprising, there was less bleeding when dropping the aspirin, but also trends toward fewer MIs and a significantly lower mortality. This was a moderate-sized study, about 600 patients, but really terrific results, I think.
This is a big problem we run into. We have a patient in AFib and some event occurs, all of a sudden they need aspirin, they need clopidogrel, and now we're increasing the bleeding. This is particularly a problem in the elderly patient. You know they're going to bleed like this. I think this is very useful information. It says if we want to preserve the value of the anticoagulation and the value of the antiplatelet therapy, we can do it without the aspirin and reduce the risk of bleeding. I think it's a big help in managing these patients. It comes to be a problem that we face almost every day.
Well, it's something that I think is very intriguing. As you say, you need both, and is the single antiplatelet therapy with clopidogrel enough in the drug-eluting stent? In this moderate-sized trial, it looked like it. I think it'd be nice to see, and I think there are a few other trials ongoing with this strategy. If this emerges, this could become a guideline-changing thing. A little premature now, but certainly something I'll start thinking about. Now, another study is the PRAGUE-12 trial, and this was a surgical trial looking at patients who are undergoing CABG, randomized to getting a maze procedure or not if they had either persistent or paroxysmal atrial fibrillation. And they found a benefit when looking at the incidence of atrial fibrillation at follow-up 3 months and a year out, with a reduction in the number of patients, or percentage of patients in atrial fibrillation. Now, interestingly, there was a difference in those who benefited. The paroxysmal AFib didn't really seem to get much of a benefit, that about 60% of them were in AFib again a year later. But those who had longer persistent AFib seemed to get 50% of them were in sinus rhythm as opposed to 25% at follow-up. So I think nice data in a randomized fashion of the value of adding a maze procedure.
And this question comes up all the time. You have a patient in AFib, you're going to have to send them to surgery for bypass surgery or some other procedure, and the surgeon asks you, should I do a maze procedure? I think the data here, particularly in the patient has persistent AFib going into the procedure, says that they're going to get a benefit from it. They're going to have less AFib coming out, even though if you looked at survival data and everything, it's not that different between the maze group and the non-maze group. The fact is that half of the patients or more are out of AFib after the maze procedure. Personally, I run into a lot of quality of life issues with the AFib, and people are grateful not to have the AFib. So it looks like there's a benefit. It's not as good as we would like to see it, but it's certainly there, and particularly with persistent AFib, it looks like it's useful.
The final study was a registry, a 10-country registry, looking at about 1,400 AFib ablation procedures. This was a multi-center, obviously, study, but just a registry. The findings, I think, were consistent with what we've seen before.
That's right. I mean, we're still seeing the information that around 70 or 75% of people at the end of a year are out of AFib, but 25% are not, and about half the patients will still be on a medication at the end of a year, whether or not they're in AFib or not. So we've known that from the clinical trials. We know it from registries. I think it strengthens our perspectives and what we can tell a patient about what to expect if they go for an ablation for AFib.
Well, very much indeed. So I think a very exciting day here with lots of new procedures and new strategies of how to manage high-risk patients. So from ESC 2012, I'm Chris Cannon.